Okay. Let's just start by everybody introducing themselves, and then we'll kind of get into it. We can start with Lucas.
My name is Lucas. I'm an ER physician.
Cool. And how long have you been in emergency medicine now? I guess if you maybe just medicine in general.
About 15 or 16 years.
Ooh, you're that old? No, just kidding.
65
Getting
years
that
old.
Not 30 yet. Well, I mean, I am 30. I haven't been doing it for 30 years.
Yeah.
Ben, what about you?
I'm Ben, last name redacted, I suppose. I'm currently an educator at a state college for the paramedic programs and EMT programs, and I started EMS in 2005, so I guess coming up on 20 years next December, so 19, very nearly.
Nice.
About half and half, started out as an EMT and then went to paramedic.
We were partners a couple of times on the ambulance,
That's right.
I remember.
Yes, yeah. Partners du jour.
Yeah. What about you, Kendra?
Well, my name is Kendra. I have been a nurse for almost 10 years. All of my training has mainly been in med surg. I did that for 3 years, and then I switched over to emergency medicine. And so I've been down in the ED now for 6 years.
Okay.
So I've enjoyed it. It's been a change that I actually have fostered in. I thought for coming out of nursing school, I thought I would only be a med-surg nurse. I was like, that was my bread and butter. It was comfortable. And then I was convinced to come down to the ED, and I feel like I've really thrived down there.
Nice. How long have you been doing charge nurse stuff?
Actually, I started doing charge 6 months after coming down to the ED. So they had a lot of turnover with people either changing shifts or leaving the organization. And they asked me to step up and kind of do charge. I thought it was going to be just a relief thing, and I got hoodwinked into doing it permanently. So
Was this during COVID or something when we lost a lot of people? Or?
Right before COVID.
Okay.
So we had a couple people who just left because they were moving, and then as you know, a lot of people covered the day shift positions, like you've been on nights for so long. So they had a couple of those open, and then people went to day shift. So then as I was coming on, there was four of us, I think, they all got kind of hired on at the same time, and then there was only 3 other people who had already been on the shift. So, and then 2 of those were already charge nurses, and then they were just like, hey, would you think about it? And that was one of the reasons why I had moved down to the ED, was so I can get more experience of leadership, because I was looking for that in med surg, and I just wasn't given the opportunity to do so.
That's some of what I want to talk about too, is kind of leading the department as a charge nurse, because I see kind of ancillary what you guys do. But I think that's a really tough role, especially when you start to deal with provider and nurse, personal conflicts and stuff like that. I'm sure you have to deal with quite a bit.
Yeah.
So that's one thing. I guess we can kind of start off there. Let me think about what my questions were here. Well, let's just start with this. What advice would you give someone that's aspiring to be a charge nurse? Let's say they're already an ER nurse.
I would definitely say have some experience. I feel like that was a drawback for me, is I didn't have a lot of emergency room experience when they asked me to do it. So I was very unsure of myself going into the position. I was like, well, this person has been here 2 more years longer than I have. Why are they not asking them to do it? Because I feel like as charge, you should be able to provide relevant information to help somebody get through difficult situations or things like that. And I feel like it's developed as I've gone through. But for someone who's looking at wanting to enter that position, I really feel like you should at least have a good set foundation of knowing the safe things to do and kind of knowing your facility's protocol before moving into that position. And then just having the desire to say, hey, I feel like I can lead, or you've noticed it. I feel like a lot of the people who, at least at North, since I work at the level 3, who come into that role have been nominated. So it's not somebody who's busting on the doors I want to do this. This is what I need to do. It's more of hey, I've seen this in you. I think you'd be a really good leader. And I feel like that's where a lot of our good leadership has come from people who are nominated, instead of coming in and saying, this is what I want to do, because those are the type of people who have a hard time navigating that role and taking good feedback, because they feel like they already know it.
Yeah, I think people that seek out those leadership positions with very little experience, those maybe are not the people you want in those roles. So It makes sense to kind of have a nomination process.
Yes, we've had a few that have come through who were just well, I feel like it's my time now. I should, do charge. And it's like, no, I don't think you should. I'm like, you either don't have good communication skills, or you're not a strong nurse, or just other variety of different things. But it's just like, I don't feel like it would be a good fit, or not just myself, but other people are like, you don't help the department gel together. And that's kind of like how people will say, oh, I feel like I should be in a trauma bay. And it's like, no, not yet.
Well, and everybody's probably
get nominated.
Yeah, and everyone's paced a little different too. I mean, some people might need a couple years, maybe someone only needs 6 months, but
Correct.
I mean, everybody grows at different rates, so that makes a lot of sense.
We have one charge nurse. She also was a new grad, and then I think stepped into the role maybe about 2 years in, but she's a very solid, strong nurse, so it makes sense. And then you have people who've been around for like me, who've been down in the emergency department maybe like 5 years before they stepped into a role like that.
Right.
So.
How do you handle conflict between staff members? Like between nurse to nurse, or even nurse to provider, or even just tough situations that roll into the department that have kind of taken a toll on all staff. I mean, do you have any advice for like how you handle that kind of stuff?
I feel like it's one is hard to answer. I feel like it's just kind of something you have like innately in you. So I feel like I'm the type of person who I can talk with a lot of different personalities. I'm not too afraid to confront somebody. I'm like, hey, like this is what's going on, but not in an attacking way. It's more like, hey, I've noticed this last couple of shifts, what's going on? Do we need to talk about it? Do we need to step aside? Or I kind of try to like help them move through the situations. Like, hey, what can I do to help you get to where you need to be? Or what do you need to step back for a second? Or do you need a minute? And it's like, okay, let's let you go home, or whatever those type of things are. So I feel like that's one way that I kind of help when people are having a difficult situation. When it comes with interacting with the providers, I actually feel like working with you guys have been amazing. Like when I started on med-surg, like I didn't know who my docs were. Like, and then the older nurses, they knew them, but they didn't actually know them. Like, oh, I know that's Dr. So-and-so. He works Monday through Friday, whatever. I see him, but they don't know them. And I feel like being down in the emergency room, we have more of a personal relationship with the docs. So you can like joke around with them. You talk to them. Sometimes you hear about their outside lives outside of work, which makes it a little more easier to be like, hey, so-and-so was kind of offended by what was said, or whatever, or you can like kind of get in, be like, hey, he didn't really mean that, this is what was really going to happen, or blah, 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 and kind of lead them around there. So just having that part of being able to talk with the docs really helps you to kind of diffuse that confrontation between docs and nurses. And then I still maybe am very old school. Like I do really feel like the doctors are still running everything, and then my job is just to help assist, facilitate it for them. So.
Yeah, that makes sense, because I feel like a lot of times we are short with each other in the heat of the moment, either provider to nurse or vice versa. And so it makes sense to like get to know people, because then you don't take things personally when you know people. You're like, oh, okay, we were all under a lot of stress. They didn't mean anything by that. And then you can let things roll off you a little bit more.
Yeah.
I feel like running with the fire department, we don't know those guys as much as you do like the other ambulance crews. And so you're much more likely to take things personally when they're not really meant that way in the heat of the moment sometimes. And I just remember that on the ambulance a lot, is you just take things personally when you don't know the people you're responding with. So in the ER, it's a lot easier to get to know people, and so you don't have to take things as personally, and it makes it much easier to operate as a team, I think. And one thing I've noticed you do that I really appreciate, that took me aback the first couple times you did it, was when you come on as charge nurse, you come up to intake where I'm, seeing the new patients coming in, and you're like, hey, how's your day going? But you actually ask it in a way like you want to know the actual answer. Like, how are you actually doing, as opposed to like, oh, hey, Aaron, how you doing? And I was like, did something happen today? Like, why are you asking me like how, you actually wonder how I'm doing? But then I was like, this is a really good thing to do, I think, to actually get a good feel for how everyone's actually doing. So
I feel like I'm just I'm a people person. Like I really do like to listen to people's stories and hear like what's going on. I'm like, hey, did you just have a vacation? Or when you get back, I'm like, oh my God, how was Greece? You went to Greece recently or whatever. But I feel like your department works better when you're more personal with everybody. And like, I don't have to know like a deep amount about you, but to show like I have some interest to recall the last thing you told me or whatever.
Right.
Like I think I saw Hennings once. I was like, oh my God, how was your competition? And then like we sat down and talked about that, or just like, hey, how do you prep for this? This is crazy. And then I'm like, that's cool.
Yeah.
But then I remember that and try to make sure I bring it into other conversations so it doesn't feel like we're just like ships passing in the
Right.
night. It's like, oh, there's actually a connection there somewhere.
Yeah, like Lucas, what's your body fat percentage today?
I really
you know?
don't
like, that's-
remember that part.
that's what I'm like,
Yeah,
I
Kendra
do
doesn't ask that very often.
I do remember him prepping for meals, and I was like, I can't do that. I like to eat everything.
So Aaron, you were asking, I just would like to add something. So you're asking Kendra what advice she would give nurses for someone who aspires to be a charge nurse. And charge nurse is a good charge nurse is a different personality. They're problem solvers. They're not just doers. They're thinkers. They're problem solvers. And when everything is going well, everything is easy. What makes a good charge nurse is when things are not going so well. Working with Kendra, she may question why she was put in charge role so easily, but for me, that's an easy answer. Like, she's very personable. She gets to know everyone, and she solves problems. So when I'm in the emergency room and I'm the attending physician, I don't really view myself as the captain of the ship. I view the charge nurse as the captain of the ship. My job is to take care of patients. Her job is to take care of every patient. So it's a little more far-reaching. But being a problem solver, rather than just someone who carries out tasks that they're told to do, and everyone needs someone. Every organization needs someone to carry out tasks that they're told to do. But if you want to be a charge nurse, you got to solve problems.
Yeah, that's a good distinction. I think even like going from EMT to paramedic, EMT's very much, you got to do a bunch of steps. You kind of do what you're told. It's very task oriented. And Ben, maybe you can speak to that a little bit, but transitioning to paramedic, now all of a sudden you need to think clinically and like, what are the differentials we're thinking of? What treatments? What's the plan here? Can this patient go in their own car to the hospital? Do we for sure need to take them by ambulance? Is this someone we can say, hey, you really don't need to go in at all? And that's kind of the difference in thinking too, I think, going from EMT to paramedic. But I don't know if you've seen that, Ben.
Absolutely. That's one of the key differences that I tell either both our advanced EMT students or our paramedic students is you might be used to letting somebody else do the planning for you. And as the higher level care provider in the field, you have to be the so-called adult. You have to be able to make those decisions and organize things and whatnot. And that is a skill. It's not just something that comes with like the shinier patch. It's something that you actually have to develop. And that's one of the hardest things that actually people transitioning from EMT to a higher level of care have, is knowing how to appropriately sort of allocate their resources, because the rookie move is they're like, well, I'm the paramedic, I've got to do it all myself because I can't trust anybody else to do it. Or they'll just be like, I need you to do this stuff. And then they think it magically happens and they don't understand like the time or the effort involved. So that's actually one of the things you said you want to ask about was how education has changed for paramedics. And that's part of it, is that one of the big things that's been a big change that we stole from nursing and from medical school is the simulation-based training that is much more integrated now into paramedic, and we're integrating it all the way down the line, even to EMT, so that instead of just practicing a lot of skills, every level is practicing now these high-fidelity simulations in context that are taking real time, so that when somebody says, I need you to start an IV, and I need to drop this med, and I need you to go ahead and get a 12 lead in this, they realize very quickly that's not all going to happen at once. It has to be, given its own timetable, and they have to allow for that. So I think that is a big part of the transition from EMT to medic. It's a related skill set of having to know who's where, who's doing what, and that conflict resolution. You referred before to some of the culture clash sometimes between EMS and fire-based services, because I think a lot of the communication issues are just for anybody is a misunderstanding. It's people thinking they know what the other person's job is, but not really knowing it, and making assumptions about it and coming to it with their own sort of lens. And if you don't know the firefighters, if there's 200 firefighters in the city, and you're regularly seeing maybe like 16 of them, then you're always going to be meeting these people who are vaguely familiar, but you have no sense of how well they're going to do. And so it's much easier to take umbrage. Whereas if you know somebody, if you're working with somebody regularly, it is a lot easier to build that bridge and say, oh yeah, I know that you didn't mean that. Let's talk about how that came across.
Taking umbrage. I love that word.
It's
Umbrage.
I'm a big word nerd.
I took a lot of umbrage when I was a paramedic. We'd bring in, like, the example I always give is you bring in a patient and give a report, and the nurse is like, well, do they have an IV? And you're like, well, no, they don't have an IV. We were right across the street, and I was busy, and I had a bunch of other stuff. And they're like, no, we just need to know if they, so we can do it if you didn't do one.
Yeah, well, that's a cultural thing with paramedics. We all have chips on our shoulders.
Yeah.
As an industry, I think, partially because we're like, why do we get paid so little? Why does nobody appreciate
Right.
this? Why do I have to wake up and not get paid differentials at night?
Right.
You know, all that sort of stuff. And the other thing is, I don't know, we're still a baby industry by comparison. You know, modern nursing, I mean, has not been around for that much longer, like maybe the 50s, 60s, 70s. But nursing as a profession has been around forever. You know, physician has been around forever. But EMS is a baby, and so you've still got this sort of, you know, take us seriously.
Right.
Yeah.
I was reading
attitude.
Kevin Hazard's book where he talks about the origin. I'm only partway through it, but I don't know how he did all this research, but he talks about, I mean, back in the 70s and probably in the 80s, cops were throwing people in the back of a hearse-like vehicle and just, you know, zip into the hospital. No one rode in the back with them. They just threw them in the back, and hopefully they survive on the way to the hospital. And it's just a weird origin story for EMS.
has some roots back in the funeral home industry too. Really? They would go out with their hearse, and if the person lived, they would take them to the hospital, but there's no care given whatsoever. Yeah. And if they die, then they get business and they take it back to the funeral home.
Wow,
it's pretty,
and it's more advantageous when the patient died, because that's actually where they would make the money.
Oh wow!
Yeah, it's a little sordid type history, but
we still worked with a guy, Josh, who worked at the last funeral home based EMS service in Colorado.
Wow.
Who was still, as of like 2012 or so, still working on the streets here, and told me specifically, you know, some days you'd run on one person, you know, driving the same vehicle as an ambulance, and then later on pick them up in its other capacity.
Wow.
So
that's wild.
Yeah, it is.
I want to pivot just a little bit about kind of some efficiency stuff from an ER standpoint that we haven't talked about a lot in the ER, Lucas, but what are like some documenting tips you would give new providers and like efficiency stuff regarding that?
So documentation wise, I have some opinions, some pretty strong opinions about documentation. And one of those is that your charts, the like base of your chart, the skeleton of it should look the same for every single patient, no matter what. It should look the same for an ankle sprain as it does with a heart attack. So it's hard because we had to balance all these requirements from Medicare and CMS and all sorts of stuff. And then you also need to tell a story. So it's kind of like you're doing two things at once. To make things as efficient as possible, I would highly recommend that you, as a provider, you have you have a template that is very basic, and it's the same thing for every single patient. Your physical exam, ideally you want a full physical exam that you put in your template that you can do without even touching the patient. Now, I am not saying at all to not examine a patient, but your basic exam should be done from the doorway. General, you can see what their eyes look like. You can see if their abdomen's non-distended. You can see if their respirations are labored. You can see if their mentation is normal. So even without physically touching someone yet, you can do a very detailed exam, and just put that as your template in your chart. Then get very detailed on the specifics. So if it's an extremity fracture, I would want to know where they're tender. Is it open? Is it closed? What the distal pulses are like? Can they move? If it's an ankle, can they move certain each toe? Can they feel a sensation? Is their Achilles intact? I want detailed. But if it's an ankle sprain, I don't need to know anything about someone's cranial nerves. That is completely irrelevant. I also don't need to know if their abdomen's tender. I don't need to know, a lot of things that I see in charts. So you need to tailor it specifically to each complaint, but then have the skeleton of it the exact same. And that really helps. It helps with communication. It helps medical legally, but it also helps document a very good chart very quickly as well.
What advice do you have like regarding stuff in the chart for like medical legal protection? Is there certain phrases or things you like to say? Because I know you have some experience with that as well.
That's kind of difficult because that's like a case by case basis. So let's say there's an elderly person with a neurological complaint. You've got to have a lot in there to say that it is this, it isn't this, this is why I did this. So it's very difficult to say like just generically add these elements and don't add others. But to protect yourself medical legally, you want to document what was done and you want to do what was documented. And I see a ton of cases where I'm reviewing charts for peer review or for legal consulting or something, and I'll go back to the ankle sprain thing, and they've got cranial nerves grossly intact, and they've got pupils equal and reactive. That automatically makes you a liar if like the attorney says, did you actually for this ankle sprain take the light and look at someone's pupils? And the answer, if you have it documented, should be yes. And if the answer is yes, why? So document what was done and do what is documented. And also another thing is more isn't always better. So being concise but very accurate and communicating very clearly is so much better than having 6 paragraphs in your medical decision-making thing that just ramble on and go all over the place. So those are to like say specific things. Like there's very specific things about abdominal pain that I say in my chart to protect medical legal, but I would honestly have to go through like each complaint and each diagnosis to really give accurate things. Right.
Yeah, I see a lot of newer APPs, I think, doing more rather than less in the chart, and kind of the rambling, like a lot of irrelevant stuff that probably doesn't protect them as much as they think, as opposed to just focusing on what the chief complaint is and saying why the patient's safe to go home. I mean, I don't think you have to write 6 paragraphs, and maybe that's the error a lot of them make.
Yeah, more isn't better. And the other problem with more is that you're taking away from your, let's say, I've always got to work off examples. Let's say I'm evaluating someone with abdominal pain. My abdominal portion of my chart is not just clicks. Like I free text the whole thing. It's soft, it's non-distended. There was no pain with movement, but there was tenderness here. There's no rebound. There's no, it's very, very, very detailed for the specific related thing. And then all the irrelevant stuff I don't even put in the chart. And then in the MDM, I do pertinent positives and negatives. So I don't need to say, the sodium's 134, the potassium's 3.4, the creatinine's 0.8. I don't need to say that because the labs are right there. Now, let's say it's a patient with a history of hypokalemia. I will say like, they've got acute vomiting and diarrhea, history of hypokalemia, but potassium's normal because that's relevant. So document basically what I'm saying is document twice as much as you think you need to on all the relevant things, and everything else don't document at all or make it very, very short, very minimal.
What other tips do you have regarding like efficiency or workflow in the department? That's going to be a kind of a long answer as well. It's also different from someone who is new and someone who's seasoned, whether it's a nurse, a doctor, paramedic, PA, NP, whatever it may be. When you're new and you don't know, you question things, you need to document more, you need to order more tests to be safe. And then with experience, you can start knocking that down more and more and more. Kind of batch things. So if I'm going to get up and see a patient and there's 2 or 3 new patients to see, I'm going to go see all of them. And then I'm going to come down to my computer and I'm going to put orders in and do other things rather than say, I'm going to go to room 16. I'm going to see the patient. I'm going to do every single thing for the patient. I'm going to document their chart. And then I'm going to get up and I'm going to go right next door to room 17 and start all over again. And again, more is not better. What is better is the right things rather than more and more and more things. So especially when it comes to testing, the right tests, when it comes to treatment, the right treatments, rather than taking a shotgun approach. Sometimes you have to take a shotgun approach. You've got an altered patient who can't say anything. You've got no history, no family.
you're going to be ordering a lot of things. That's normal. But try to cut out the things that are irrelevant, and don't use them as crutches. Like a lactate, I don't need a lactate on every patient. I'm selective in who I order those on. And when I get the answer, I know what I'm going to do with it. And when I order the test, I know what I'm looking for. If you can't say what you're looking for, then don't even order it at all, just because you think that needs to be done.
I have heard that. So I'm going back to school to get my NP, and I've had professors say that, like, if you order it, then you're responsible for it. Like, don't go out there looking for zebras and order this random test that you don't even know it's for, and then it comes back, and then you're like, what do you do with it now?
Right.
Like, or it wasn't needed, and now you have to speak to it because you did it. So that makes a lot of sense too.
And you should, from your history and your exam, you should know 85% of what you need to know with no test whatsoever on most patients. Again, we're talking about averages over all patients that you see. I would have a personal goal of like clinching the diagnosis 85% of the time with no test whatsoever. The tests are made to help confirm what I'm already suspicious of. I'm not using the test to bring about brand new information that I didn't even think of.
Right.
So that can cut down a lot. Your documentation, the things we talked about earlier, and having a template that has everything out, and then you just put in a lot of detail, the pertinent positives and negatives, documents a good chart that flows very well, that communicates very well, and it takes way less time than just kind of clicking all over the place. And then at the end, you're like, well, I don't even know what this patient is here for.
Right.
Yeah.
And I would add, from my limited experience compared to yours, don't stack orders if you can really avoid it, because that really bogs down the department, especially for nursing.
That's a really good
stacking
point.
Orders is like, you put in a couple things because maybe you sat down real quick and you just, okay, they need this. And then you go back and you're doing their chart and you're like, oh, I want to add this. And then I want to add that. And it really slows down the whole department when we do that.
Yeah, sometimes that's inevitable. But you should, again, let's just use the 85% rule. 85% of the time, you should not order any new orders whatsoever after your initial order set. Sometimes you need to add something because there was a surprise, or we're all human, right? We forget to order a troponin on a chest pain. Like, that's pretty important. But you shouldn't piecemeal things. You shouldn't piecemeal treatments. You shouldn't piecemeal tests, because that's just your efficiency, but you're also really affecting the nurse's efficiency too. Another thing is doing the same thing every time in the same way. If I'm doing a procedure, if I'm doing a central line, my stuff, no matter what room I'm in, no matter what floor of the hospital I'm in, no matter where, my stuff is always in the exact same place. So I have a method where I set things up. I do the same, or I do things in the exact same order. I have my equipment in the exact same places. It's kind of like the checklist manifesto for pilots. The more boring you make it, the safer and more efficient it is. And when I say boring, that's a little tongue in cheek. It's not like doing a central line is boring, but it should be done the exact same way every single time.
We talk about that with paramedics a lot too, especially with intubation, like the higher risk things that we do on the ambulance, like have everything laid out, and then you're not going to need everything,
Yeah. Don't leave it to chance. Make sure that you've got everything done. You do it the same way every time. It's the same old. Why does the nurse at my primary care physician office tell me to uncross my legs when she takes my blood pressure? It's not because it has any effect. It's demonstrated it has, like, if I cross them way high up, it may be 5 points over 5 minutes. It's because it's doing it the same way every time, right? So that it's just got that standardization.
Yeah.
And confidence is something that comes for people with time, but it has to be worked on. Like, you should try to work on being more confident, not arrogant, not ignorant, but confident, meaning like, I am confident in my evaluation of this patient, in the questions I asked, the test I ordered, the treatment I gave, the discharge instructions I gave. You have to be confident in that. And that will make you a lot more efficient as opposed to if you're second guessing everything, then you're just constantly, it's not even thinking, it's more like second guessing. Yeah, second guessing frequently is not a good trait. So taking a pause when a pause is needed, when something doesn't fit, something changes, vital signs change, something just doesn't feel right, something was pretty surprising in the labs, pause and think. That's not the same as second guessing every single thing you're doing.
Yeah.
I'd also add plan on a negative workup too, because our positive workups, I mean, these are all emergent tests. So when something's positive, it's a no-brainer what to do with it usually. I mean, you need to talk to a specialist. They need to be admitted. You need to give them a specific treatment for it. But when we plan on everything negative, especially when we work as a team, you know, being a PA, we work as a team with the docs most of the time. So it's when everything comes back negative, we already have a plan together. We're not waiting on things to come back to decide what to do. We already have a plan, assuming everything's negative. Because if everything's positive, I don't need to talk to you about, oh, this patient has a brain bleed. I'm going to start consulting specialists, putting in orders for treatment. Positive results are easy. You know, it's when everything's negative, what are we doing with this patient? You don't have to wait for everything to come back to have that specific plan.
And when it comes to efficiency too, think one step ahead. So when I'm seeing a patient, I am already planning, is this person going home? Are they being admitted? And what steps do I need to take to safely get them home? What kind of follow-up do they need? What kind of discharge instructions do I need to give? If I'm admitting them, who do I need to talk to? Who do I need to consult? What procedures do I need to do? And I'm not waiting until the very end to do that. I'm thinking that the second I see a patient, I'm like, okay, that person is going to need this, 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 and this. And then I kind of am able to put it in my workflow of patients, which also brings up another good point is how you handle your patients. So I will see a critical patient, and then sometimes you don't have time between seeing a critical patient and then maybe you need to do a procedure or something else to like go see a brand new abdominal pain. But I would have time to pre-discharge 2 or 3 of my patients while I'm sitting in the trauma bay watching my critical patient, but I'm awaiting something. Then I can go in someone else's chart and start discharging, hitting prescriptions I need, but I can cut that off at any point and then get up and do my procedure or whatever it is that I need to do.